I guess the question was, you said locally advanced. What does that mean?
Well, in this case, let me see. I think in this case, they didn't. I think it's pretty. It's just talking about. They kind of generally said arterial and venous involvement. I'm guessing they're talking about SMA and superior mesenteric vein.
You mean locally unresectable pancreas cancer?
Locally advanced unresectable, right? Because of the SMA encasement. Okay, so if you go to the next one, they use PET CT. I think probably because this patient is a CA19-9 non-producer to try to follow, because these are kind of difficult to follow. And then I think he was going to pull up CT, but we'll go to slide number 8. So you can see there's extensive SMA encasement, greater than 180 degrees here. There's also the complexity of a replaced common hepatic artery coming off the SMA. And then the SMV is encased, but apparently reconstructible in this situation. And then they mentioned that the coronary vein was free. I have a question for Barnes-Jewish. Like, why do you think they would mention that the coronary vein is free in terms of the portal vein drainage?
This is Barnes-Jewish. I guess it might be to do with potential drainage and reconstruction options in terms of the target, because there's complete encasement of the SMV.
Yeah, I think ultimately it's just talking about the drainage for the stomach. You know, if sometimes with these large venous resections you have to divide the splenic vein, for example, then the stomach can get kind of congested, and having that portal vein free up top with some coronary vein going into it is nice because it drains the stomach. I think that's probably why they inserted that comment in there. Okay, so going to slide number 9. So let's say this patient is responding well. How far would you push the FOLFIRINOX? How many cycles? Providence, Portland?
Yeah, we like to typically push to 8 cycles. We tend to re-image every couple of months while they're on neoadjuvant treatment. But we find that a lot of times by 8 cycles, many patients are starting to really have some of the bad effects of chemotherapy start to emerge.
Right. I think that's a really good point, because certainly, as you might imagine, you can give as much chemo as possible and drive down everybody's marker as low as possible, try to kill the micrometastatic disease, but then at the same time, you'll end up knocking down the patient to the point they can't have surgery. So yeah, I think most people say 8. Is there anybody online who would do totally neoadjuvant therapy and do 12 doses or 6 months? Anybody?
It's Brendan here from Stanford. But outside of the Mayo, isn't this an unresectable tumor? Like unresectable? Like, you know, for most places, this is a no-never, right? With complete encasement, unless you get, so this is not neoadjuvant. This, at most centers, and definitely a quote-unquote board answer, this is an unresectable tumor. So then it is not just a question of how many cycles until what's next, because this is not borderline. This is unresectable based on the description you've given us, absent extraordinary circumstances and a couple of surgeons.
Yeah, right. I think, Randy, you make a very good point. Yeah, I mean, you know, on your board exam, this is an unresectable tumor, no doubt. I think they were just showing the most extreme example of downsizing. So let's say it was not quite.
So Jingwei, so before you go on, do you just want to comment? I mean, we have 3 different running versions of resectability as far as guidelines go. I mean, maybe it's worthwhile just talking about that. And then second of all, we're really talking based on your, you know, the publications from MD Anderson, we're talking about anatomic borderline resectability as opposed to sort of the CATS A, B, and C. Do you want to just spend a moment regarding that?
Sure. No, I appreciate it. So certainly, so if you look at locally advanced, most people would agree it's arterial encasement of your hepatic artery, celiac, or SMA greater than 180 degrees by technical definition. But of course, that you know, some people will skim beyond that depending on how aggressive the surgeon is. When it comes to borderline, what Rohan was talking about is, you know, many years ago, back when I was in fellowship, we developed an ABC model for borderline: A for anatomy, B for biology, and C for reversible comorbidities. And the concept was most people were just talking about the anatomy, so that's BRA. But there's also borderline biology, meaning people who have a high CA19-9, like 1,000, or have nodes on presentation, or have indeterminate nodules that you kind of want to follow with the test of time. So that's the borderline B. And then there's borderline C. Those are people who have comorbidities where, you know, they may have a reversible cardiac issue, and you kind of have to bide some time. Or if they have a performance status requires some prehabilitation, these are people who aren't necessarily knocked off. And by using this classification, you can create a clinical classification rather than just looking at straight up anatomy. There is, you know, if you look at the NCCN, SSAT, SSO, HPVA definitions of anatomically resectable, it means straight up, no venous contact. That's probably the strictest definition. Some people will allow a kind of a gray area of potentially resectable where you have a tumor that's touching the vein but not really indenting or encasing it. When it comes to venous contact, you know, in terms of what's called unresectable, well, I think it also depends a little bit on what Brendan's saying and how aggressive the surgeon is, but ultimately it's not a matter of length of how much vein is involved, but whether it's reconstructible, where they have a landing zone above and below the area that you're planning to reconstruct. So I think that's kind of how I would think about the classifications. Any other thoughts on that?
Yeah, why don't we ask Carolina's what they use as their definition of borderline resectable?
Hey, Carolina's here. So for us, obviously, borderline resectable, we still use some of the classic definitions, but we are a little bit more aggressive in regards to being permissive with short segment encasement of the SMA. We do use IRE here, and so we will use IRE to enhance margins for resection, either in patients that have had neoadjuvant or have not had neoadjuvant therapy. And just depends on the intraoperative findings. Obviously, there are still cases where we get in and we find that the patients truly are unresectable, and that usually involves extended involvement of the SMA, and at times, sometimes the celiac axis as well.
And Kathleen or the group at MCW, I know you guys are very aggressive with this, but based on the data from MD Anderson, really response to neoadjuvant chemotherapy is unlikely to be seen. Do you look for a radiographic response, or do you just base this on tumor markers?
So typically there isn't a great radiographic response. We follow the CA19-9, but that's not, basically that doesn't necessarily prohibit us from operating.
So
as well, to see if they're reconstructible, especially.
Okay, so based on what we have over here, let's move forward from the concept that Brendan was bringing up, that this is what's being presented as an unresectable patient, but let's assume that this is a borderline patient, and what would be the next step? Let's just keep moving on with the presentation, if that's okay, Ching Wei.
Sure, yeah. So moving on, I think the next part he put in with the presentation was to talk about adjuvant therapy. And again, we're talking about neoadjuvant, but why are we talking about adjuvant? We're just talking about the regimens and kind of where the regimens came from. So I think slide 11 jumps to probably the biggest study that's come out in the past year, and that's the Pradesh 24 trial. And hopefully people got a chance to read this. This is from France and some Canadian hospitals. And what you see here is they randomized almost 500 patients between adjuvant FOLFIRINOX and gemcitabine. And I think, you know, what sticks out the most to me in looking at this is that obviously you can see the FOLFIRINOX has better disease-free survival and better overall survival. Amazingly, the gemcitabine has the longest survival ever seen in any kind of trial, right? We're talking about a median survival in gemcitabine arm that's in the 30-month range, when previous studies in the past have always hung at exactly 20 months. And so anybody have any idea as to why they think the gemcitabine arm, before we talk about the intervention arm, why the control arm was so good? University of Toronto, maybe, General Hospital? Why do you think the gemcitabine arm was so good in this trial?
Toronto, can you jump in, please?
Or Sunnybrook?
Sunnybrook?
Yeah, I'm not too sure I understand the question as much as to and have a good explanation for why the gemcitabine was so good in this trial as compared to the historical trials.
Yeah, and the reason I ask this question, anytime you look at people jump to the p-value or jump to the differential, you can see these curves separate dramatically. So you kind of have to look at the control arm. This control arm is dramatically better than any clinical trial ever before. So you kind of have to look at what kind of patients and whether they're generalizable to your typical North American patients. So, these patients were the median age 64, so relatively young, right? Only 19% of them were over age 70 something, and all had a good performance status. Gemcitabine patients, gemcitabine patients who recurred later on were allowed to be salvaged with FOLFIRINOX, so there's crossover to FOLFIRINOX as well. So there's a number of issues as to why this control arm is so much better than all the things you've seen from CONCO-1 all the way to, say, SPAC-4. So this is something to keep in mind. Nonetheless, I think the take-home from this is that FOLFIRINOX is kind of the ultimate or ideal for adjuvant therapy if a patient can have it. Now, I'd be curious to hear, let's say from Cleveland, let me ask Cleveland Clinic, in terms of adjuvant therapy, let's say somebody did have surgery up front, what chemotherapy agents would you use for your typical American patient?
So a lot of it, like you said, depends upon the comorbid state, the ECOG functional status, how much the patient can tolerate, things of that sort. We have switched to FOLFIRINOX for a lot of the patients who actually have very good functional status, and that goes for the neoadjuvant also. But for the other subset of patients, gemcitabine is what most of our oncologists prefer. Is that what you were asking?
Hey, this is Mike from Mayo. Can you guys hear me?
There you go, Mike. Hey, Mike.
Hey, guys. Sorry, we've been having some technical difficulties here. Can you guys see my screen?
Well, why don't we go over and switch over to Mike then? Qingwei, thank you so much for being the fellow on the call.
Sure.
If you would take over as the moderator. And then, so Mike, if you would take over from here, we're talking about the study, and we need to sort of try to get through some of your slides over here. We presented the case and talked about this. So if you could go on, and we were talking about the control arm doing very well in the study, and that, where most of us would consider using FOLFIRINOX in the adjuvant. Jill, just to save time, can you maintain control of the slides? And Mike, just tell Jill to move forward, please, so that we can keep going.
Hey,
Sure,
Rowan,
so you guys just finished.
Rowan, this is Bill Hawkins at WashU. I think the point was started to be made but never completed. Why this control arm did really well is that at entry into the trial, this is a group of patients who you knew might get FOLFIRINOX. So this is the best 20–30% of our patients entering this trial. And if you know a patient is going to get randomized to FOLFIRINOX, they're a much better than average patient entering this trial.
Yeah, that's exactly right, Dr. Hawkins. I mean, this is Qingwei again. This is the issue when you read these randomized trials. You have to be careful about trying to extrapolate to your typical American patient, and you might say, well, we should resect everybody up front and just give them modified FOLFIRINOX. But even in these healthy French patients, only 60% got it all. And these people also had a capped CA19-9, so the best biology and the best recovery. They had to recover before they could even be enrolled on the trial. And so it doesn't take away from the findings of the trial, but that's one of the putative reasons for neoadjuvant therapies to put the effective chemo on the front side. But I'll let Mike take over. Sorry, Mike, go ahead.
So Mike, I did have one other question for you with regard to this trial. Our definition of R1 is different in Europe and in the US. And my question is, I was trying to look in this paper, but I don't know if they use the Leeds definition of R1, i.e. being less than, I believe, 2 millimeters on ink, or if they used tumor on ink as an R1. The R1 rate was 40%, which is actually relatively low for Europe. So I didn't know if you had any insight to that.
I wasn't able to determine precisely what they used as well, so I'm not entirely sure about that.
Anyway, do you have any insight into that issue?
Yeah, I don't know if they used the 1 millimeter rule or not, but I think you make a good point that the quality, here's the problem with a lot of these post-surgical trials, the quality is randomized on the back side, but on the front side, the quality is not controlled in terms of surgery. You know, like 40% is pretty high for margin positive.
All right, let's keep.
Can we go to the next slide, please? And sorry, Jill, is this my screen that's sharing? Because I do have an updated version of the talk that I was hoping to present. So would it be possible just to quickly transition to my screen, and I'll get you guys to exactly where we are right now?
Sure. It looks like you're talking from Patrick Starlinger, so I'll make him the presenter.
Yeah, we've had a lot of difficulties. I'm talking on a phone, but my computer should still be up and working, I'm hoping. So can I share my screen and then let's load kind of an updated version of the talk? Is that possible? I apologize for the inconvenience.
No problem. I just sent Patrick control to be the presenter, so it's all you. You'll just need to push share my screen.
Okay.
Quick comment about while he's working on this trial in FOLFIRINOX. The group that we struggle with now, because we mostly give FOLFIRINOX, are the T1, T2, N0. You know, these are often the incidental pancreatic cancers. Obviously, the trial was not powered for that, but there was not a difference in those early cancers in FOLFIRINOX versus gemcitabine. So we go back and forth about whether a very early stage cancer should go ahead and get the FOLFIRINOX. That seems still unanswered.
Sorry, Jill. I'm talking on Patrick's phone, so, but the screen should be under my name.
Oh, okay, no problem. I'll switch to my problem. Hang on.
Sorry, I know this is awkward. Yeah. Okay, there we go.
Can you switch to presentation? Yeah.
Sorry. Get rid of that thing. There we go. Okay, can you guys see that then?
Yes.
Sorry, can you guys hear me? Okay, sorry. So the next trial that I wanted to discuss in terms of how we ultimately choose what we're going to give in terms of systemic chemotherapy for individuals in the neoadjuvant setting was the Apec trial. So this was a phase 3 multi-center international open-label randomized controlled trial of gemcitabine and Abraxane versus gemcitabine for individuals with surgically resectable pancreatic cancer. So in this group, treatment-naive patients with histologically confirmed pancreas cancer and who had a macroscopically complete resection and a good performance status, as well as a CA19-9 less than 100, were ultimately eligible to be enrolled. Treatment of, in terms of the adjuvant therapy, was initiated within 12 weeks of surgery. Ultimately, they had 866 patients who were randomized, and when they looked at the investigator-assessed disease-free survival, it was 16.6 months in the gemcitabine Abraxane group versus 13.7 months in the gemcitabine group. And interim overall survival was also increased in the gemcitabine Abraxane group versus gemcitabine. Now, they did have an independent reviewer disease-free survival, which didn't show any statistical difference between the two groups. In addition, treatment emergent adverse events greater than grade 3 or more were reported in 86% of the gemcitabine Abraxane group versus 68% in the Abraxane alone group. So ultimately, I guess to sum up these adjuvant trials is that multi-agent regimens are more effective than single agent, but of course that's going to come at the cost of increased toxicities. So I was wondering if anybody had any more comments on that before I proceeded.
So, one thing is that our local oncologists have, within Texas Oncology, have taken that trial to indicate that as a negative trial, and actually have sort of in their pathways moved away from Gem/Abraxane in the adjuvant. But you're saying that we should consider that in the adjuvant. Is that right, Mike?
Yeah, that's what I am suggesting. I mean, I recognize it wasn't, a huge increase in the statistical significance. Certainly in the interim overall survival was, borderline with a p-value of just under 5. But it did suggest. Like
and I think, I think the issue with the independent observer difference was the issue. Anyone in the group want to comment on that? What are you guys doing? Are you using Gem/Abraxane adjuvantly or just in the neoadjuvant? How about Virginia Mason?
Hey, Rohan. Yeah, so we were just discussing these because obviously we have a conundrum here because we haven't compared the combination chemos between Gem/Cape, Gem/Abrax, and FOLFIRINOX. So we tend to use a lot of Gem/Abraxane, believe it or not, both in the neoadjuvant and in the adjuvant setting, partly because, the population we tend to see is a little bit older. So our median age, I would say, is probably hanging around over 70. But certainly we don't have the answer yet. Till 1505, reads out, we don't know what the optimal agent is for peri-op therapy. The other issue is that Gem/Cape, the Xeloda doses that are used in Europe of 1250 are much higher than anybody here in the US can tolerate. So nobody can really give Gem/Cape, at least in our hands, as well as they did in Europe. But the jury's out.
Qingwei, what do you guys think? Because again, this could be with the independent observer data, you could use this as a negative study.
Right. I think that some people, I agree with what you're saying. There are a lot of oncologists who are interpreting this that GA is no better than G alone. But either way, I mean, this is a very select patient population. Again, looking at this modern cohort, the Gem alone survival is incredibly good compared to anything ever seen before. But I think maybe what you should focus on is in these trials now is the disease-free survival, because think about it, all these people are allowed to cross over to a salvage agent for their overall survival. So maybe the disease-free survival is a better endpoint here, and where you do see the GA pushing out the disease-free survival more than the gemcitabine. And this is kind of what you see when you give patients neoadjuvant therapy. It pushes out the recurrence-free survival, and then the overall survival comes together with those with the surgery first with adjuvant therapy. So I do think, just like Flavio said, there's 3 options: FOLFIRINOX for the super good, and then if you're not quite there, in the middle you have either Gem/Cape or Gem/Abraxane, and then for the elderly patients, Gem alone is still a viable option.
Rohan, this is Susan Tsai. Can I make a comment?
Please.
So I think for the institutions that are heavily invested in neoadjuvant therapy, the use of Gem as a single agent or Gem/Nad is very reasonable if you've given them neoadjuvant and they have a good clinical and like a radiographic and biochemical response. So even though the Apec trial, again, which, in some ways it's being criticized for using disease-free survival because it's very subjective based on imaging, what time that person actually truly has a disease-free survival event or disease recurrence event. If based on their neoadjuvant therapy that they've responded to it, I don't think that we should just take Gem/Nav off the table as in the adjuvant setting for those high-risk patients.
Good point.
Yeah, that's an excellent point. Should we keep going?
Qingwei, this is Rob Martin, but that is a totally different subset. This study was for patients who were chemo naive and were surgically resected. That extrapolation that if they get neoadjuvant, that is not this study subset. And clearly, if someone is getting Gem/Abrax, they've responded, they've had a biochemical response, they've had some pathologic response, of course those patients should stay on. But to state that the Gem/Abrax was a truly positive study again, we're just not seeing that, and so those the fellows need to make sure there's a clear distinction. If they're getting neoadjuvant, sure, I think everyone agrees they should stay on that active agent. If they've had surgery first, Gemabrax is not that widely accepted because of this study and because of the potential toxicity versus Gemzolota, which is better tolerated.
That's a good point. Yeah, I think if you had a choice between Gemabraxane and SPAC4 to Gemcape, then you'd go with the SPAC4 to Gemcape because it's got better different.
Well, Mike, you brought up a lot of controversy here. Let's keep moving.
Okay. So next I wanted to hone in and discuss obviously more trials that have and investigations that have been done specifically on neoadjuvant therapy after we've kind of discussed what are the systemic therapy options that exist out there, and again using that adjuvant therapy trials or those adjuvant therapy trials to inform us as to what to do. So first we'll focus on locally advanced and borderline pancreas cancer. So the first paper from this part of the talk that I wanted to focus on was from our institution. Where ultimately the goal was to identify what are the predictive factors of survival for individuals with borderline and locally advanced pancreatic cancer. Ultimately, this included 194 patients who received neoadjuvant therapy, then subsequently went on to surgery. Now, in this group, margin negativity was 94.3%, while 80% of patients had lymph node negative disease at the time of resection. When we looked at how well they responded to their upfront therapy, which included both chemo and radiation, there was a complete pathologic response rate of 10%. 28% of patients had a near complete response. About 50% of patients had a partial response, and then about just over 10% had poor to no response. Of note, there were 67 patients within this cohort who had baseline and interval post-chemotherapy metabolic imaging. And in this group, 97% of patients had FDG avid lesions prior to treatment. What we mean by FDG avid is an SUV greater than 5. Post-chemotherapy, complete metabolic response did correlate with major pathologic response. So there was an 80% positive predictive value that if the patient went from FDG avid to no FDG avidity above the background parenchyma of the pancreas, this had an 80% positive predictive value of having a complete or near complete response. Whereas if they did not achieve this objective, then 100% of the patients would not have a complete or near complete response. There were ultimately 3 factors that were associated with improved recurrence-free and overall survival, and this included greater than 6 cycles of effective chemotherapy to which there was an objective response. If they had an optimal post-chemotherapy CA19-9 response, meaning that it went from elevated to normal, so less than 35 at our institution, and if they had a major pathologic response, so complete or near complete. If they had none of those factors, overall survival was 18.5 months, and 3-year survival was quite dismal at 8.3%. Whereas if all 3 factors were met, their overall survival was greater than 77 months, and their 3-year overall survival was just shy of 95%. Now, this did exclude patient 90-day perioperative mortality. So this was patients who survived beyond that 90 days after the surgery. I can stop there if there's any questions or comments about that, or I can continue on.
Jingwei?
Yeah, I mean, I think that the advantage of neoadjuvant therapy is that you can look at the response. We found similar things. Obviously, if you have complete response, it's really awesome. No guarantee. You can still die from metastatic disease. But you know, the response rate is still quite low. I think it's going to be 5 to 10% for complete path response. And the question is, what about those who just have quote unquote major response? You know, does that lead to anything? And then the other question to ask for those who do neoadjuvant therapy is the response from the chemo for those who get chemo alone, or is it a response from chemo plus radiation? You know, you might imagine somebody who gets true response from chemo alone is going to do much better than somebody who gets artificial local tumor response from radiation. The question for Memorial, what do y'all use in terms of neoadjuvant, in terms of looking, in terms of path, what are the things you look at on a path report to try to either reassure you, yourself, or reassure the patient? You know, what are the path report things you're looking at?
Mentioned the major pathologic response or complete pathologic response, lack of lymph nodes, obviously, lack of the standard prognostic factors, but beyond that, we haven't found any significant predictors of a good outcome. Like you said, even a phenomenal response can lead to a metastatic outcome. So I think the jury's still out for us on any new prognostic factors beyond the ones that are accepted.
MCW, do you want to comment on this as being a site that sort of this is near and dear to you? Medical College of Wisconsin.
Sorry about that. This is Rebecca Kim. I'm the fellow. So yes, we are very strong proponents of neoadjuvant therapy. In fact, we're basically pushing total neoadjuvant therapy where they get essentially 4 months of chemotherapy and then a gemcitabine-based radiation therapy before going to surgery. Was the question more about what are we looking at in terms of the pathology now, or?
Right, on the pathology report, what are the things you're looking at on the pathology report after neoadjuvant?
Right, so typically we're looking, like Lamoral said, the margins, the nodes, the response to chemotherapy on that pathology.
Perfect. Shall we keep moving?
Shima, can I ask a question briefly?
Yeah.
And I'm just gonna for those who are giving total, we don't usually give radiation ahead of time, but for those who are giving total neoadjuvant chemotherapy, how often, especially with really moderate to poor response rates on pathology, how often are you giving chemo afterwards? And why are we calling it total neoadjuvant chemotherapy if we're giving often chemotherapy afterwards?
Yeah, to me, total neoadjuvant therapy is defined as all of it up front and none afterwards. We don't personally call it total neoadjuvant. We actually have tried to, even though we use the word neoadjuvant a lot, try to call it more perioperative, kind of a la MAGIC trial. You know, try to give most of it up front, so in case you do have a complication, at least you got multimodality therapy. But if you recover well, which is the plan, hopefully, you get a little bit on the backside, acknowledging that on the backside, typically there's a 30% dose reduction. So we try to put as much on the front side as possible, 4 months. But we've personally, at MD Anderson, not called it total neoadjuvant. But there are people who advocate for it because they figure they can get the most in before surgery is accomplished.
Mike, why don't you keep going?
Okay, in the interest of time, I'll skip forward here a couple of slides. I just wanted to touch base about the Alliance trial because this is going to provide, I think, some future direction. So this is a trial that's currently ongoing and it had 2 arms. The first arm was modified FOLFIRINOX for 4 stages, or 4 cycles. They restaged and then went back on FOLFIRINOX and ultimately went to surgery. And then there was another arm where they had modified FOLFIRINOX and then ultimately went to radiation therapy preoperatively. The primary objective was to estimate 18-month overall survival of patients with borderline resectable cancer. In interim analysis, they looked at R0 resection rate. Interestingly, the radiation therapy arm met its futility endpoint at interim analysis and closed at interim endpoints, and so the chemo-only arm reopened to full accrual. So in this particular study, there wasn't a ton of benefit in terms of your ability to achieve an R0 resection when radiation therapy was employed in the neoadjuvant setting. So
this trial took a long time to get going, the Alliance trial, and I think it is huge that it actually got accomplished so quickly. I think it's because there was the dearth of trials in this field. I think the biggest point made here was that the 2 arms, one inserted radiation therapy into the arm. You know, one had 8 cycles of FOLFIRINOX, the other had 7, and then the SBRT. The SBRT was a politically sensitive subject that took a lot of time in negotiations. And you might say, why not just radiation? Why was it SBRT put in there? And that's, again, a very political thing in the cooperative group. And then, interestingly, despite putting that in there, the radiation oncologist wanted it in there. In the end, it was futile in terms of increasing R0 resection, which is another point I wanted to point out, right? One of the putative reasons we've always thought about using radiation therapy was to help with our margins as surgeons, but interestingly in this randomized trial, it did not.
And Chinwei, if I can just add, this is Rob Martin again, and if I can add a caveat to that again so the fellows understand, there is the distinct difference between SBRT and then 5 weeks of neoadjuvant IMRT. And so
Right.
this was pure SBRT. The other thing that was also a big confounder in this study was the timing of surgery after the last dose of SBRT. The first 5 centers that enrolled in the phase 1, we all agreed we were going to operate within a week to 2 weeks out of the last dose of SBRT to make sure that we did not have a significant amount of peri-radiation inflammation. And that's why the phase 1 study went so well, and then we had this big lull. This trial required a number of other centers that did not have the use of operating after SBRT, and they waited sometimes 4, 6, 8 weeks. And then when they got in there, the patients were locally advanced unresectable because of the huge amount of inflammatory effects. So there are significant caveats that the fellows should understand. This was a futile study, but there are significant caveats in regards to when you decide you're using SBRT and when you operate, have significant amount of operative morbidity or even success, and you need to take that into a consideration depending on what site you go to where SBRT may still be a very viable choice for these kinds of patients.
Right, that's a good point.
Mike, we've got 12 minutes, so I want to make sure that we cover the key points here.
Okay, so lastly, I wanted to talk about the role of the adjuvant therapy in potentially resectable individuals, and there's not a ton of data in this particular area, but this is a meta-analysis that I was going to discuss. So this included studies where patients had resectable as well as borderline resectable pancreas cancer treated with upfront surgery or with neoadjuvant therapy. And they reported median overall survival by intention to treat. There were ultimately 38 studies that were included with a total of just over 3,400 patients. All studies that used at least chemotherapy as neoadjuvant treatment. Most of them included gemcitabine, so that was 26 out of 35 studies. Radiation therapy was also given as a part of the neoadjuvant therapy in 29 out of the 35 studies, and no study used radiation therapy alone. The radiation dose ranged from 30 to 54 gray. The weighted median overall survival by intention to treat was 18.8 months in the neoadjuvant therapy group versus 14.8 months in the upfront surgery group. And among patients whose tumors were resected, the survival, median overall survival was increased even more, so it's 26.1 months versus 15 months. The overall resection rate was lower with neoadjuvant therapy than with upfront surgery. Adjuvant therapy was initiated in 10 out of the 12 upfront surgery groups, and out of that cohort, 68.6% of patients who underwent resection ultimately started adjuvant therapy. So about 1 in 3 patients wasn't able to get through their surgery and recover and have an adequate performance status in order to be able to receive the adjuvant therapy. Additionally, about 1 in 5 patients who received neoadjuvant therapy were not able to proceed to exploratory surgery. So certainly there's a selection bias that goes into this. Patients who progress on neoadjuvant therapy ultimately have poor biology, and they're going to do poor, and obviously they'll be excluded from that group who ultimately undergo resection. So the R0 resection rate was higher, so it was 86.8 versus 66%, and reported by intention to treat, that value did decrease, but of course there was that 1 in 5 patients who ultimately didn't go to the OR. The lymph node positive rate was lower after neoadjuvant therapy, and the overall resection rate was also lower in patients who had neoadjuvant therapy as opposed to upfront surgery. So in terms of future directions, looking at the use of neoadjuvant therapy in potentially resectable, this is the SWOG 1505 study, so a randomized phase 2 trial of perioperative chemotherapy, so 12 weeks pre, 12 weeks post-op, with either modified FOLFIRINOX or gemcitabine or Abraxane. They use only resectable with the disease, so no arterial involvement and less than 180 degrees of venous involvement. And primary outcome is going to be 2-year overall survival rate. So again, this will be informative. Ultimately, there's 103 eligible patients who are included at this point. Out of that, 96% of the patients have started and 86% completed their preoperative chemotherapy. There was 1 death due to sepsis, and 61 of those 99 patients had grade 3 or grade 4 toxicities. And to date, 77% of the patients have gone on to surgery, and most of those patients were ultimately resected. So 72 out of the 76 underwent resection. So that's just the interim data that's available on that. So just to kind of put a summary, I think that in order to achieve long-term survival in patients with pancreas cancer, we do have to think about employing multimodal therapy. So this is going to consist of systemic therapy as well as local regional therapy. And of course, if we're going to treat them in a neoadjuvant setting, we need to have predefined goals in terms of what we want to accomplish and what do we want to achieve and what are our endpoints. So in terms of choosing induction chemotherapy, again, using evidence from the adjuvant setting and translating it to the neoadjuvant setting, it seems as though multi-drug regimens have a higher efficacy, but of course come at the expense of increased toxicities. In terms of our objective goals and endpoints, we did touch base in terms of patients have a clinical response, biochemical response, radiographic, and metabolic, and I think before I kind of got involved in the talk, some of that had already been discussed. As to how frequently we should restage these people, I mean, none of the evidence really supported exactly what the time frame should be, but by convention, typically every 2 to 3 months, we should consider restaging these individuals and make sure that we are achieving the goals that we're setting out to achieve. And then ultimately, what is going to be the duration of therapy that we deliver in the neoadjuvant setting, and should there be any therapy given in the adjuvant setting? So I can stop there for any other questions or comments from the other groups.
So I guess, let me ask Ascension, because I think part of this is to find out what people are doing around the country, because this is such a murky sort of subject. But Ascension, if you have any venous involvement, are you calling those patients borderline resectable and treating them up front, or are you taking them straight to surgery, even if it requires some sort of vascular reconstruction?
Hi, it's Tamara. So here at Ascension, for venous involvement with borderline resectability, we tend to be a little bit on the more aggressive side. So there are times where we will take the patient to the operating room and then perform a vein resection in those cases. And some of this is kind of based on the patient's overall status, like their ECOG status. So if they,
yeah, so I don't know why that is, but I mean,
there are, in some patients' cases, we will give them neoadjuvant chemotherapy, but for the most part, we tend to be aggressive on the vein resection.
So
let me ask Carolina's, would you call that patient with less than 180 degree involvement resectable or borderline resectable?
Hey guys, so I would say that there's a lot of variability based on from one attending to the other, and someone like you're describing. So one person's borderline might not be the next attending. So if I certainly, this is John, by the way. So if I have anybody with any vascular involvement whatsoever, they're going to get neoadjuvant therapy up front, and that's just the way I've moved my practice. I think some of my partners will be more aggressive and resect up front with venous involvement, with the knowing that they're probably going to need a vein resection. I would say if we looked at we've looked at our data, and unfortunately, doing that, you're going to get a higher R1 resection rate by doing surgery up front, and that's just our data. So I looked at, when we look at our data, it's always worse than you think it is. So nodal involvement in R1 resection. So over the last 10 years ago I've changed. But that's sort of the protocol here. It's just one attending may not do the same thing as everybody else. I don't know if that's right or based on data, but it would be nice to see if you hadn't presented any data on people with purely resectable as opposed to upfront versus neoadjuvant, or unless I missed it because I got here a little late.
So we had a little bit of data at the end, John, but I think that's the question. Stanford, what are you guys doing at this time?
It's Brendan. We have largely moved to giving some period of upfront chemotherapy, 2 to 4 months. I'm not doing total neoadjuvant therapy, quote unquote total neoadjuvant therapy. You know, there has to be some reason not to. So occasionally older people, you know, the medical oncologists are more hesitant. Cystic lesions, for example, that have a suspicion of adenocarcinoma, there's some more uncertainty about what to do. But I would say our default is to give neoadjuvant chemotherapy unless there's some other extenuated circumstances that murky the waters.
So one other question I just had for the group is, you know, the issue of margin status, because if you look at the data closely, when you look at margins being, you know, within a millimeter of ink as being a positive margin, you actually have a lower R0 rate, but those R0s do better, which means that in most of our experiences, we're probably mixing in some R1s with the R0s. And the question is, you know, do we need to be more standardized on pathology? For example, we actually ink our SMA margin, which is our most frequently positive margin. Qingwei, you want to take that on and tell me what you think?
Yeah, sure. I think the issue with the margins is people have, like you said, usually mention on the pathology how we ink it, but actually I would turn it back on us personally on this as the surgeons, right? The pathologists can only ink what's given to them. They can't tell if there's still tissue left behind on the SMA. And that's why I think in surgery first, a lot of surgery first patients, there probably is a lot of tissue still left behind that hasn't been sterilized either with pre-op chemo or radiation. Now, in all our data, in all the patients ever performed MD Anderson in 20 years, margin status has never been anything on any multivariate analysis, because margin status is more of a tumor biology issue. You can't help as a surgeon. If you see bare white on the SMA, there's nothing more you can do. Then it is up to the multimodality therapy to take it over. So it is important to get a negative margin, and it is important to ink it correctly, as you're saying, for the SMA. But ultimately, I think we should turn on ourselves as surgeons. We have to clear the SMA. That's what we can do for the patient.
Memorial, do you want to give us your perspective from New York?
We can go with most of the group. I think for neoadjuvant therapy, if they're clearly resectable, we hew towards resection up front. There is some practice variability based on attending. We would consider vein involvement or vein abutment borderline. Most of our attendees at this point are giving upfront chemotherapy 2 to 4 months, depending on how the patient does. We tend to prefer FOLFIRINOX upfront if the patient can tolerate it. But it is still attending dependent, so there's not a memorial approach, so to say.
Perfect. Qingwei, you wanna take us out? We're just at the end of the hour over here. Thank you so much for stepping in. And Mike, thank you for the presentation. I'm sorry you were having technical issues. Qingwei, you wanna summarize?
I think there's still a lot of answers here to, you know, a lot of questions that still require answers. I think ultimately the easiest to answer going backwards is locally advanced, right? Everybody agrees you got to do something. Borderline resectable, I think the pendulum is swinging, but I think where the questions still are out there are on potentially resectable or anatomically resectable, however you want to call it. The people you could take straight to the OR tonight, whether they would benefit from neoadjuvant therapy. You know, every institution has their biases, including our own. Things we didn't talk about today, that would be for another thing, would be talking about complications after surgery and how they can preclude your adjuvant therapy. So I think there's still a lot to answer there, and I think as surgeons we can work together to hopefully answer those questions going forward. But thanks everybody for your attention.
Thank you so much, everyone, and this worked really well. Jill, who is our next presenting site and our next moderator so we can look forward to this?
Sure, let me pull that right up. Okay, so the November grand rounds will be held on November 6th. Stanford will be the moderating site, and Toronto General Hospital will be the presenter. The topic will be colorectal liver metastases.
Perfect. Thank you all very much for joining, and have a great night.
Thank you. Hey, Rohan, it's Mike Jacobs. Thanks for hosting this. That was excellent.
Thank you so much, Mike. It's great to have you guys.
Yeah, thanks again. Have a good night.
Thanks, Jill.
Thanks, everyone.
Thanks very much.
Indeed.
This talks because again, different classification systems.